We often talk about health threats, right? But sometimes the biggest dangers are kind of hidden. Widespread threats you might not even realize are escalating. Today we're doing a deep dive into one of those, sepsis and septic shock. It's a really complex and critical medical condition. He gathered comprehensive medical sources, looked at the latest research, clinical guidelines, all to pull out the most important insights for you. So our mission today, to help you quickly but thoroughly understand what sepsis actually is, why it's so dangerous, how it develops, and the latest ways medical teams are fighting back. We want to arm you with some maybe surprising facts and just critical awareness about something that affects millions.
Absolutely. And this deep dive, it really is meant to be a shortcut for you so you can grasp the profound impact and the sheer complexity of this life-threatening condition. You'll understand why sepsis is such a constant, urgent focus for healthcare providers everywhere, and honestly, why this knowledge is just vital for everyone.
Okay, let's unpack this. When I first started looking into it, I thought infection, like maybe a bad cut or a nasty cough, something localized. But the sources suggest sepsis is, well, much more than that. Is it really not just a severe infection, but something fundamentally different in how the body responds? What exactly is it, and how is it different from septic shock?
That's the absolutely crucial distinction. For a long time, there was quite a bit of confusion, but the Sepsis 3 consensus, that's the third international consensus definitions, it defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection.
Okay, dysregulated host response. That sounds key.
It is. And then septic shock, that's a more severe form. It's described as a subset of sepsis in which underlying circulatory and cellular metabolism abnormalities are profound enough to substantially increase mortality. So the key takeaway isn't just the infection itself, it's that dysregulated host response. Your body's own immune system essentially goes haywire, overreacts, and starts damaging its own organs. It's not just an infection. It's your body's life-threatening, chaotic reaction to the infection.
And what's truly staggering when you look at the research is just the sheer scale of this. I mean, it's not just a hospital concern, it's a global health crisis, isn't it?
You're absolutely right. The numbers are, frankly, alarming. Sepsis and septic shock. They are the leading causes of death in non-coronary ICU patients. Worldwide, sepsis hits more than 31 million people every year.
31 million.
Yeah, and more than 6 million people die from it annually. But here's the part that's really kind of shocking when you dig into it. Despite decades of advances in antibiotics, critical care, everything, hospital admissions for sepsis have actually tripled over the last decade.
Tripled. Wow.
Tripled. So this isn't just about more people getting infections. It really highlights a profound and growing challenge that, well, our current approaches aren't fully tackling at the population level.
That feels like a cruel irony, then. That so many of these really dangerous infections, the ones leading to septic shock, often start right there in the hospital. So where do these infections typically come from, and who really needs to be most aware of their risk?
Yeah, it's a huge challenge. A lot of these critical infections start in places like the bloodstream, that's bacteremia, or the lungs causing pneumonia, the urinary tract leading to urosepsis. We also see infections inside the abdomen, wound infections. But what's increasingly a concern are infections tied to common medical devices, things like IV lines, urinary catheters.
Seems meant to help.
Exactly. They can unfortunately become entry points for bacteria, especially when a patient is already vulnerable.
So the hospital environment itself, paradoxically, can be a risk factor for people who are already sick.
Precisely. And beyond those hospital-acquired infections, there are other factors driving up the numbers. We're using more invasive medical procedures, more indwelling devices. We're also dealing with more antibiotic-resistant bugs, which is a huge problem. And critically, our global population is aging. Yeah, so when we look at the high-risk groups, older adults are definitely especially vulnerable. They often have decreased physiologic reserves, their immune system might be aging, they have other health conditions. And sometimes they don't show the typical signs of infection, which can really delay diagnosis.
That makes sense.
Other high-risk folks include patients having surgery or other invasive procedures, especially if it's an emergency or they need multiple surgeries, people with malnutrition, weakened immune systems, and anyone with chronic illnesses like diabetes, hepatitis, chronic kidney disease, or various immunodeficiency disorders.
That really helps paint the picture. Okay, so how does a, let's say, localized infection trigger this a massive body-wide crisis. What's actually happening inside?
Right, so it starts with the microbes, the bacteria, viruses, fungi. Historically, we blamed gram-negative bacteria most often. But now we're seeing more and more gram-positive bacteria, viruses, even fungi causing sepsis. And here's something really surprising. In up to 30% of sepsis patients, believe it or not, we never actually find a specific source of infection.
30%. Wow. Okay.
Yeah, so once these microorganisms invade, they trigger that dysregulated immune response we talked about. Think of your body's alarm system. Normally, it calls for help, fights off the bad guys. In sepsis, it's like it pulls every fire alarm in the building simultaneously. It floods the system with chemicals, cytokines, inflammatory mediators, things that are meant to help heal, but in these amounts, they cause widespread damage.
So the body's defense system essentially turns on itself.
Yeah.
Causes more harm than good.
Exactly. That's a good way to put it. This cascade then leads to poor tissue perfusion. Basically, blood isn't getting where it needs to go efficiently. Imagine your tiny blood vessels, normally tight, suddenly becoming leaky. Fluid escapes into tissues, and they also widen abnormally vasodilation.
Okay.
That makes blood pressure plummet. And the result? Your body's cells are starved of the oxygen and nutrients they desperately need. Now, for years, we used something called SIRS systemic inflammatory response syndrome criteria. Things like fever, fast heart rate, to flag potential sepsis.
I've heard of that.
Right. But here's a critical insight we've gained. Those SIRS criteria alone, they're actually not that helpful in diagnosing sepsis. The real game changer is focusing on that dysregulated host response. It's not just inflammation. It's the body's chaotic reaction that defines sepsis. And there's more. This inflammation also messes with your clotting system. It triggers unnecessary clot formation.
Oh, wow.
Yeah, so you get these tiny clots blocking microvessels, which makes perfusion even worse. And at the same time, you use up your clotting factors inappropriately. This whole imbalance between inflammation, clotting, and the body's ability to break down clots, that's really critical to how devastating sepsis becomes.
That paints a really clear picture of the internal chaos. It sounds like an absolute race against time. So when those initial attempts to compensate start failing, what does that rapid decline look like for the patient?
It is a rapid and very critical progression. In the early stage of septic shock, the patient's blood pressure might actually be normal or maybe low, but it responds if you give them IV fluids. Their heart rate speeds up, becomes tachycardic. They often have a fever, warm, flushed skin, maybe strong bounding pulses. Respiratory rate is high. Urinary output might be normal at first or maybe start to decrease. You can see GI issues, nausea, vomiting, diarrhea, things slowing down. The liver can start showing signs of dysfunction. Bilirubin levels rise, clotting problems get worse, platelet counts might drop. You also see signs of hypermetabolism, blood sugar goes up, insulin resistance develops. But here's a really, really crucial early sign that's often missed. Subtle changes in mental status. Confusion, maybe agitation, that can be one of the first.
Confusion and agitation. Okay, noted.
Yeah, and lab tests will show elevated lactate levels, high inflammatory markers like white blood cell counts, C-reactive protein, procalcitonin.
And then as the body loses this battle.
As sepsis progresses towards full septic shock, tissues just aren't getting perfused. They become acidotic. The body's compensation fails. The cardiovascular system starts to give out. Blood pressure doesn't respond anymore, even to fluids and strong medications called vasoactive agents.
Right.
Signs of end organ damage become obvious. Acute kidney injury, severe lung problems, liver failing. That confusion we mentioned. It can progress to complete unresponsiveness. At this point, blood pressure plummets. The skin becomes cool, pale, maybe mottled. Temperature might be normal or even low now. Heart and respiratory rates stay really fast. Urine production just stops. And multiple organs fail, which progresses ultimately to death if not reversed.
It's terrifying how fast that sounds. Given how quickly and devastatingly this progresses, what are medical teams doing? How do you manage something moving that fast? Time must be everything.
Time is absolutely critical. Decades of research have led to constant reevaluation by critical care experts. This gave us evidence-based recommendations like the Sepsis 3 guidelines we mentioned, and these efforts directly led to developing and using sepsis bundles. These are specific, time-sensitive protocols focused on prevention, early detection, and management.
Sepsis bundles, okay.
And implementing these bundles has significantly reduced mortality rates in hospitalized patients. It's made a real difference. The key concepts from Sepsis 3 for providers really hammer home that sepsis is the top cause of death from infection. It needs super prompt recognition and treatment. It reinforces that sepsis is different from just infection because of that dysregulated host response and the organ dysfunction. And crucially, that organ dysfunction might not be obvious right away, maybe signaling an infection you haven't found yet.
Got it.
And of course, research is ongoing, focusing on even better, faster identification, early aggressive treatment, restoring tissue perfusion rapidly, and tackling the patient's specific immune response and that clotting chaos.
Okay, so understanding that critical time frame, what are the immediate life-saving steps? When someone presents, what happens right away?
Right. The absolute first priority is rapid identification and, if possible, elimination of the infection source. The goal is to figure that out and start treatment within 1 hour. That's key for better outcomes.
Hour. Okay.
A vital step here is getting specimens, blood, sputum, urine, maybe wound drainage for culture before you give any antibiotics. You need to know what you're fighting.
Before antibiotics. Okay.
Yes. At the same time, if there are medical devices like IV lines or catheters that could be the source, they're removed or changed. If there's an abscess, it needs draining. Dead tissue needs debridement. Then you hit it hard with broad-spectrum antibiotics, ideally within that first hour. Later, once the culture results come back, you can narrow down the antibiotics to target the specific bug.
Find the source, get samples, hit it fast with broad antibiotics. What else is absolutely critical in that first hour?
Exactly. Next up is fluid replacement therapy. You have to rapidly reestablish tissue perfusion. That means giving fluids fast. Typically, it's an initial fluid challenge, at least 30 milliliters per kilogram of body weight of crystalloid solution, given IV over about 30 minutes, especially if their blood pressure is low or lactate is high.
Okay, lots of fluids.
Yep. And you're constantly monitoring how well that's working, checking blood pressure, mental status, respiratory rate, urine output, lactate levels, and seeing if they are fluid responsive. If fluids alone aren't enough to bring the blood pressure up, then pharmacologic therapy starts. Vasopressor agents, medications to constrict blood vessels, are initiated. Specifically, norepinephrine is usually the first choice, sometimes dopamine. The goal is to maintain a mean arterial pressure, or MAP, of 65 millimeter Hg or higher.
Right, depressors.
Exactly. Other drugs might be used to inotropes to support the heart muscle, maybe packed red blood cells if hemoglobin is low to help carry oxygen, and other supportive meds like maybe sedation to reduce the body's metabolic demands, or drugs to prevent blood clots like DVTs and stress ulcers.
And you mentioned those sepsis bundles. How do they organize all this? Are they like checklists?
Pretty much, yeah. They're time-sensitive, evidence-based checklists or protocols. The 1 hour bundle is crucial. It dictates that within 1 hour of recognizing potential sepsis, you need to measure the lactate level and remeasure if it's high, get those blood cultures before antibiotics.
Right, crucial step.
Administer broad-spectrum antibiotics, start that rapid fluid administration, the 30 ml a kg, if they have hypotension or very high lactate, and give vasopressors if the blood pressure is still low during or after fluids, aiming for that MAP of 65 or more.
That's a lot to do in 60 minutes.
It is. And there are follow-up bundles, too, often for 3 and 6 hours, involving further reassessment of volume status and tissue perfusion. And finally, nutrition is important. Aggressive nutritional support should start within 24 to 48 hours of ICU admission, ideally through tube feeding rather than IV, as that carries less infection risk itself.
This brings up a really important point. What's the vital sort of moment-to-moment role of nurses and other frontline healthcare providers, especially identifying this early, maybe even before someone gets to the ICU?
Oh, their role is absolutely critical. It starts with prevention, strict infection control, obsessive hand hygiene, meticulous sterile technique with any invasive procedure. Nurses are constantly monitoring IV sites, wound sites, catheter sites for any sign of infection. They're also key in identifying those high-risk patients we talked about: older adults, immunocompromised, trauma patients, diabetics. And here's something really important to remember. These high-risk patients might not show the classic signs of infection or sepsis. Their presentation can be subtle.
Right, you mentioned that.
Which leads to probably the most critical early warning sign for any adult patient, high risk or not. Confusion, maybe with agitation, combined with an increased respiratory rate. That combination might be the very first subtle clue that infection and sepsis are developing.
That's such a vital takeaway. Confusion and rapid breathing. It sounds like something even a family member might notice.
It absolutely is. And nurses use specific tools to help with early detection, too. In the ICU, there's the SOFA-score sepsis-related organ failure assessment. It looks at respiratory function, platelets, liver function, blood pressure, kidney function, and consciousness level. A drop of 2 or more points from baseline in an infected patient suggests organ dysfunction and sepsis.
Okay.
Outside the ICU, there's a simpler tool called QLAO Quick SOFA. It's a screening tool. If a patient has any two of these three signs, it suggests sepsis, a respiratory rate of 22 or higher, any change in mental status, GCS less than 15, and a systolic blood pressure of 100 or less.
So quick and easy to check.
Exactly. There's also the MEWS Modified Early Warning System. It assesses changes in respiratory rate, heart rate, blood pressure, consciousness, temperature, urine output. A score over 4 is suggestive of sepsis. Beyond detection, nurses provide ongoing care, collaborating to find the infection source, getting those cultures before antibiotics, managing fever but watching for shivering, administering the IV fluids and medications like antibiotics and vasoactive agents, and closely monitoring all those blood levels, antibiotic levels, inflammatory markers like procalcitonin and CRP, kidney function tests, blood counts, clotting studies. All vital because organ perfusion can decrease rapidly, affecting how drugs work and potentially causing toxicity. Plus, monitoring hemodynamics, fluid balance, daily weights, nutritional status, it's intensive.
Wow. This has been an incredibly insightful deep dive. We've
Yeah.
gone from understanding the subtle and often deceptive nature of sepsis and its devastating impact through the really intricate physiological chaos and onto the incredibly rapid evidence-based actions medical teams take. It really underscores how critical early recognition and swift action are.
Absolutely. And what's fascinating and challenging is that constant interplay, isn't it? Between the bug, the person's individual response, and then our medical interventions trying to tip the balance back. Understanding that dynamic process is just so important.
Definitely. And as we wrap up this deep dive, here's maybe a final thought for you to consider. Despite decades of advanced antibiotic therapy, despite rigorous clinical guidelines like the sepsis bundles, the overall incidence of sepsis is still rising. And its earliest signs, as we've discussed, can remain deceptively subtle, sometimes boiling down to just confusion and a faster breath. It's a stark reminder, I think, of the profound complexity of our body's response to infection and the ongoing critical importance of vigilance and awareness, not just for doctors and nurses, but really for all of us. We really encourage you to continue your own deep dives into your health and well-being.